My name is Katherine. I am a maternal fetal medicine specialist in the Division of Maternal Fetal Medicine at Brigham and Women's Hospital. Today we will be discussing obstetric critical care. I have no financial relationships to disclose. Today's objectives are to understand the normal pregnancy physiology and how it may affect management in the ICU setting, to review common obstetric scenarios requiring admission to the ICU, such as hypertensive disease, liver disease, hemorrhage, ARDS, and the need for mechanical ventilation and sepsis, and then to review some special scenarios for pregnant women, such as advanced cardiac life support and perimortem cesarean delivery. In general, OB patients requiring critical care are rare. Approximately 1% of women who come in for delivery will need critical care services. The risks of ICU admission may be altered by age, ethnicity, the delivery volume of the hospital you're at. In general, women who are admitted to the ICU with obstetrical related complications have lower mortality rates than the general population. However, 2/3 of deaths in pregnant women occur in women who never reach an ICU. This statistic has led us to look more carefully at need for higher acuity monitoring in women who may be admitted to an ICU. During pregnancy, the majority of ICU admissions are for hypertensive disease, such as eclampsia, preeclampsia, and HELP. Hemorrhage is the second most common, and this includes antenatal, intrapartum, and postpartum hemorrhage. Pulmonary disease requiring mechanical ventilation is third. Also common are sepsis and liver disease. The reasons that women get admitted to the maternal ICU are typically for need for higher acuity monitoring, such as more frequent vital signs assessment, or because of additional available monitoring tools. There are several levels of ICU care. In some tertiary care institutions, labor and delivery may be appropriate for simply higher acuity monitoring. As the needs progress for single organ support, massive transfusion protocols, and vasoactive drugs, at this point, women may require an OB ICU or ICU. In all settings, the need for multi-organ support or mechanical ventilation will require an intensive care unit setting. This is a state database of all inpatient admissions in Maryland. This database identified all antepartum, delivery, and postpartum hospitalizations with any ICU utilization. The comparison group over here on the right is obstetric non-ICU admissions. And what you can see is among 765,000 OB admissions, they had 698,000 deliveries, approximately 3,000 ICU admissions. In the antepartum setting, the most common reasons for admission were hypertension, trauma, and cardiac disease. During delivery, the most common ICU admissions were hypertension, hemorrhage, and cardiac disease. And postpartum, we see that cardiac disease, hypertension, and now cerebral vascular accidents are the most common. The fetal outcome after maternal admission to the ICU can vary by gestational age. This is a single center experience at the Mayo Clinic and excluded women with primary OB admissions primary OB reasons for ICU admissions. About 23% were ventilated. In general, fetal loss rates are somewhat proportional to trimester. Overall prematurity rate was quite high at 49%, and overall fetal death rate was 33%. There have been some improvements in maternal mortality. However, we find overall that the maternal mortality rates, even in developed countries, are rising. And in addition to maternal mortality, there is an increase in maternal near-miss morbidity. During 2004 and 2005, more than 68,000 women nearly died in childbirth in the USA, and each year 1.7 million women suffer a complication that has an adverse effect on their health. As we mentioned previously, the vast majority of women who suffer maternal mortality and die in pregnancy, delivery, or the postpartum period do not even make it to an ICU setting. When we look at causes of pregnancy-related death in the United States, we see that cardiovascular disease is the leading indirect cause of maternal mortality. Non-cardiovascular disease, infection, and hemorrhage are the next most prevalent. This table shows the changes in maternal mortality over the last several decades. As you notice, this is in the United States, looking at cause-specific mortality. So although maternal mortality from hemorrhage and hypertensive disorders has decreased in developed countries, the proportion of pregnancy-related deaths attributable to cardiovascular disease has steadily increased, including cardiomyopathy, CVA, and all cardiovascular conditions. When you look at maternal mortality worldwide, you see that as compared with developed countries, lower resource settings have much higher mortality due to hemorrhage and infections than we do in developed countries. These rates of maternal mortalities have led to attempts to use widely recognized prediction methods in the pregnant population. There are several widely used scoring systems, including the Apache 2 and 3, the Simplified Acute Physiologic Score, or SAPS, the Mortality Prediction Model, or the Sequential Organ Failure Assessment Score, which was initially developed for sepsis and has since been more broadly applied to general morbidity and mortality. The most widely studied is the Apache 2. However, none of them have really included adjustments for normal obstetric physiology, and all of them tend to overestimate mortality risk in the critically ill pregnant woman. The largest series, looking at the Apache 2, the SAPS-2 and the NPM-2 scoring systems, compared 93 pregnant women with 96 non-pregnant women admitted to the ICU. Overall mortality rate in the obstetric and non-obstetric populations were similar, and each of the three scoring systems, although they performed well in the prediction of death, did predict higher mortality for obstetric than non-obstetric patients. The SOFA score has more recently come into common use, and they have been assessed in pregnancy in multiple small series. Generally speaking, the SOFA score performs well, although the sensitivity and specificity has varied widely from small study to small study. Some parameters, it has been suggested that some parameters such as the PO2 and to the FiO2 ratio may need to have a slightly different cutoff in pregnancy, and ultimately there is no universally accepted obstetric morbidity and mortality score. By contrast, early warning criteria, as well as differential diagnoses for each, have been developed to speed identification and treatment and thereby lessen the impact of maternal morbidities. These criteria are designed to trigger a response by an appropriately cared team. The success of such a trigger-based system requires education and training for all clinical staff so that they can identify the triggers. Early warning systems for maternal disease have taken into account the changes, hemodynamic changes that are associated with pregnancy to try to more accurately predict maternal changes as opposed to vital sign changes in the general population. When you are managing an obstetric patient in the intensive care unit, it is critical to have a multidisciplinary approach involving obstetrics and maternal fetal medicine, intensivists and critical care specialists, obstetric anesthesia, interventional radiologists, neonatology, nursing, and pharmacy. We're now going to review some of the parameters of normal pregnancy physiology to help understand how it may affect management in the ICU setting. The first and most important changes that women undergo in pregnancy are the cardiovascular changes. These begin, if you will notice, very, very early in pregnancy, and by about 8 to 16 weeks, many women have undergone some of their maximum changes in their cardiovascular status that they will experience just prior to delivery. Marked increases in circulating blood volume are met with an increase in stroke volume. You have a 15 to 20% increase in the heart rate, which occurs predominantly as you move into the third trimester. The net effect is a 30 to 50% increase in cardiac output by the end of the first trimester, and this is an effect that peaks between the second and third trimesters. During the early stages of pregnancy, increases in stroke volume are largely responsible for the increase in cardiac output, while later in pregnancy, the increase in heart rate contributes at the end. So in summary, when you look at normal values, contrasted with the changes in pregnancy, you can see that pregnant women will increase a 30 to 50% increase in their cardiac output. Their blood volume is expected to increase by 20 to 50%. Their SVR falls early and deeply in the first trimester of pregnancy, as does their pulmonary vascular resistance. In addition, their oxygen consumption increases, as does their oncotic pressure decreases, as does the pulmonary capillary wedge pressure. In summary, we see an increase in cardiac output and a low SVR that leads to a fall in blood pressure early in the second trimester. There's a modest increase in heart rate, and there's an increase in effective circulating blood volume by about 40 to 50%, with a corresponding physiologic anemia. As the plasma volume increases, the red blood cell mass increases in a slightly slower rate. Importantly, heart rate and stroke volume increase when you put the woman in the left lateral recumbent position, and if you leave your pregnant patients in the supine position, they will have vena cava hypotensive compression and supine hypotensive syndrome. These changes can occur as early as 20 weeks. During labor, the changes continue to increase, and you see cardiac output, which can be increased 12% from baseline, mostly due to an increased stroke volume in the first stage of labor. As women contract, contractions necessitate an augmentation in their cardiac output, and they have their maximal cardiac output just prior to delivery. Postpartum, 1 hour and 24 hours after deliveries, changes quickly return to normal. Importantly, in the immediate postpartum period, there is approximately 300 to 500 cc autotransfusion from the placenta, and for women with fixed valvular lesions, this may predispose them to heart failure. In addition to the cardiac changes, there are significant respiratory changes. There's upward displacement of the diaphragm and widening of the subcostal angle by approximately 50%. The end result of this is a decrease in the functional residual capacity by approximately 20%. Progesterone is a known stimulant of respiratory drive, and pregnant women have an increased minute ventilation because of this. The decrease in the functional residual capacity by 10 to 25% causes an increased need for oxygen, and an increase for oxygen consumption lead overall to a decreased oxygen reserve. The increased respiratory drive stimulates increased minute ventilation. Pregnant women are in a state of chronic compensated respiratory alkalosis. There is the reduced upper airway dimensions, and then there is a right shift of the oxygen saturation curve, which is compensatory in order to increase O2 delivery to the placenta and the maternal tissues. Estrogen also induces hyperemia, mucosal edema, and rhinitis, which may change upper airway dimensions. These changes are also reflected in maternal ABG values. As you can see, the pH is slightly higher to accommodate for the decrease in carbon dioxide. The kidneys excrete bicarb, and arterial blood gas in a normal pregnant woman will reflect this slightly increased pH, a decreased PCO2, and a decreased bicarbonate. 60% of women experience some sense of shortness of breath, which can begin as early as the first trimester. Minute ventilation will increase by nearly 50% at term, and pregnant women are in a state of progesterone-mediated chronic hyperventilation. There are other normal pregnancy findings on routine exams. We can see EKG changes such as left axis deviation. There can be increased ectopy, both atrial and ventricular ectopy. There may be some ST segment and T wave changes. On chest x-rays, there is typically a straightened left upper cardiac border. The heart may attain a more horizontal position, and the lung markings may be slightly increased. These radiographic changes may make it difficult to diagnose cardiomegaly by simple radiography. In addition, there may be some changes on echocardiogram. There are increases in the left and right ventricular dimensions, as well as mild increases in left and right atrial size. We would expect an increase in ejection fraction and ventricular systolic function. It would be normal to see an ejection fraction of 65% to 70% in a pregnant woman in her third trimester. In terms of imaging studies, these are estimated fetal exposure from some of the common radiologic procedures. Of note, the allowable total radiation dose in pregnancy is 5 rads. The CT scans probably have the most radiation exposure, but none of them are enough to achieve the allowable dose of radiation. Magnetic resonance imaging is commonly used and safe across all trimesters. Of note, recent studies have suggested that there may be increase in fetal complications with the use of gadolinium in any trimester, including a small association with stillbirth. Therefore, the use of gadolinium is not recommended in any trimester. It is important to review this with the radiologists who protocol the MRI studies, as many of the MRI studies can be safely and effectively done without gadolinium. There is a new drug classification in pregnancy. In 2015, the FDA moved away from the old labeling of A, B, C, D, and X, and now this requires that all drugs have a change in the content and format by the physician labeling rule. And so this new labeling focuses much more on assessment of benefit versus risk in the counseling of pregnant women as well as lactating women. In addition, there is a new category for females and males of reproductive potential to assist with counseling for people considering a pregnancy. In terms of medication, there are many medications that are safe for use in pregnancy. The ones to be avoided predominantly are the ACE inhibitors and the ARBs, as well as amiodarone. Particular side effects and contraindications of note are that amiodarone is linked with significant fetal hypothyroidism. ACE inhibitors are contraindicated due to renal abnormalities, oligohydramnios, and growth restriction. Furosemide, flecainide, procainamide, warfarin, and lidocaine are all safe, relatively safe, and should be used in appropriate settings where other medications cannot be used, and they should be used in conjunction with counseling of the patients. I'd like to move on now to looking at common obstetric scenarios requiring admission to the ICU. We'll begin with hypertensive disease. Hypertension is extremely common in pregnancy. Approximately 5 to 8% of all pregnancies are complicated by hypertension in some form. To differentiate, there's chronic hypertension for women who have hypertension defined as blood pressures of greater than 140/90, beginning prior to 20 weeks. Gestational hypertension refers to the onset of hypertension after 20 weeks. Preeclampsia is defined as hypertension with proteinuria. Preeclampsia also applies to non-proteinuric severe hypertension with severe features of preeclampsia. There are new guidelines that emerged in 2013 to try and better delineate preeclampsia, and so now we speak about preeclampsia with or without severe features. Eclampsia is maybe the end result of severe preeclampsia, and that refers to seizures, and the HELP syndrome, hemolysis, elevated liver enzymes, and low platelets. Women who develop hypertension in pregnancy are at risk for significant complications, including preeclampsia, placental abruption, fetal growth restriction, and preterm delivery. Hypertensive disease in the pregnant woman may present differently than in the non-pregnant population. Women who have hypertension in pregnancy are relatively more hypovolemic than normal pregnant women. So they seem to develop less robust gestational hypervolemia. They also have increased risk for pulmonary edema and leaky capillaries, so volume loading in them may result in more pulmonary edema and need for invasive monitoring. In addition, women are at risk for impaired renal failure with preeclampsia, and we should always monitor their magnesium infusion. In many women, blood volume may expand little, if at all, in severe preeclampsia. One study that looked at 44 normal controls versus 29 eclamptic women showed that in the controls, the mean blood volume was about 4.5 liters, whereas in women with eclampsia, the mean blood volume was only 3.2 liters. In general, invasive monitoring is safe in pregnancy. It is used to look at central venous pressure, pulmonary capillary wedge pressure, cardiac output, afterload, PA pressures, and mixed venous oxygen saturation. In non-pregnant states, the CVP and the pulmonary capillary wedge pressure roughly correlate. However, preeclampsia is one of the few states where the left and right side of the hearts may have different pressures, and a pulmonary arterial catheter may be helpful in determining this. For the severely hypertensive pregnant women, there are many IV therapies that are available. The American College of Obstetrics and Gynecology has recommended using either labetalol or hydralazine as first-line agents. Hydralazine is admitted at 5 to 10 milligrams intravenously. The American College of OBGYN recommends giving no more than 2 doses of IV hydralazine before switching to labetalol. Labetalol is given at 20 milligrams IV every 10 minutes, with a doubling up to 220 milligrams per hour, or continuous infusion of 1 to 2 milligrams per minute. Nifedipine can be given orally up to a maximum dose of 50 milligrams in 1 hour. Sodium nitroprusside traditionally has been avoided due to risk of fetal cyanide poisoning with prolonged treatment. However, in the ICU setting with careful monitoring of dosing, sodium nitroprusside can be used as a third-line agent to control severe hypertension. As mentioned before, women with hypertension are at risk for many complications, including severe preeclampsia and eclampsia, renal failure, HELP, pulmonary edema, neurologic sequelae, DIC, and PRESS. PRESS is a constellation of neuroradiographic findings that are thought to be related to an acute increase in arterial blood pressure, disordered cerebral autoregulation, and endothelial dysfunction. Clinically, PRESS is indistinguishable from hypertensive encephalopathy and should be managed aggressively with antihypertensive medication. For women who develop eclampsia, the goal is to control their seizures. They are typically self-limited. The preferred agent for treating preeclampsia is IV magnesium sulfate, normally given as a bolus with a 6-gram bolus with a continuous rate of 2 grams IV per hour. It also may be given IM if there is no IV access. HELLP syndrome can occur in 10 to 20% of patients with preeclampsia. This is a microangiopathic hemolytic anemia. Platelet counts are less than 100,000. There is a rise in the AST, and DIC is commonly associated with this. It is important to differentiate TTP and HUS from HELLP syndrome. TTP-HUS is a rare and potentially lethal disease that is also associated. It can also be seen in pregnancy. It usually occurs in the 2nd or 3rd trimester. TTP is defined by a severe deficiency of Adams T13 of less than 10%. However, this diagnosis is difficult to make because it is typically these labs take a while to come back. Other things on the differential diagnosis of HELLP include DIC, acute fatty liver of pregnancy, malignant hyperthermia, and lupus. Differentiating TTP from preeclampsia is important. As with TTP-HUS, aggressive treatment with prednisone and plasmapheresis will improve outcome. For preeclampsia and HELLP, the only treatment is delivery, seizure prophylaxis, and supportive care. Because so many of the clinical findings may overlap, there are a few criteria that favor TTP: an onset of illness prior to a gestational age of 20 weeks, the presence of significant hemolysis and or a very high elevation of LDH would favor TTP. In contrast, preeclampsia may typically, and HELLP syndrome may particularly present with severe hypertension, liver dysfunction, and the AST being increased is a feature that may distinguish preeclampsia. The management of HELLP is mostly supportive. We typically stabilize the patients, and if greater than 34 weeks, we'll deliver them promptly. If less than 34 weeks, we would consider steroids to accelerate fetal lung maturity and deliver after 48 hours. Magnesium is initiated for seizure prophylaxis. Hypertension is controlled with labetalol, nifedipine, or hydralazine, and delivery is the only treatment. There are some small observational studies that report pregnancy prolongation with dexamethasone. However, these have not been shown to improve fetal or maternal outcomes long term. For instance, the studies, although they may have delayed a precipitous fall in laboratory studies, overall there was no decrease in hospital stay, transfusion, maternal complications, or need for ICU admissions. In HELLP, the maternal fetal outcomes are largely based on age of diagnosis in terms of the fetal outcomes. The later the diagnosis, the less premature the baby is, and the better outcome the fetus will have. There is significant maternal morbidity associated with HELLP syndrome, including abruption, renal failure, liver rupture. So we've reviewed normal pregnancy and hypertensive disease. We're going to move on to liver disease now. Acute fatty liver of pregnancy is a microvascular fatty infiltration leading to liver failure. It is very rare. Sometimes the clinical features can be difficult to distinguish from preeclampsia. The onset is typically late in the 3rd trimester. Women may present with non-specific symptoms. Usually, acute fatty liver of pregnancy is differentiated from preeclampsia and HELLP by abnormal coagulation profile, a very low glucose, and an elevated ammonia level. Diagnosis is based on clinical features, and liver biopsies are rarely performed. Once the diagnosis is established, delivery is the only treatment. Typically, supportive care will involve correcting hypoglycemia and coagulopathies. Renal failure will accompany liver failure in approximately 60% of cases, and dialysis is often needed. Women may need TPN for associated pancreatitis. However, most women will recover without the need for liver transplantation. Interestingly, the pathogenesis of acute fatty liver pregnancy has been thought to be similar to inherited defects in mitochondrial oxidation of fatty acids. There have been numbers of studies now that have shown that many of the women who develop AFLP have identifiable LCHAD mutations. The outcomes in women who develop acute fatty liver pregnancy have improved drastically over the course of the last 30 years as obstetric care has improved and ICU care has improved. However, fetal mortality rates remain elevated, and they are predominantly driven by the gestational age at which a woman presents. We're going to move on now to hemorrhage, which is one of the most common causes of ICU admission. Hemorrhage is defined differently for vaginal birth and cesarean section. Hemorrhage after vaginal delivery is considered a blood loss of greater than 500 cc's, whereas for cesarean delivery it's greater than a liter. It can also be defined as a hematocrit drop of 10%. The measurement of estimated blood loss at delivery is notoriously inaccurate. Worldwide, hemorrhage remains a leading cause of maternal morbidity and mortality. Postpartum hemorrhage can be divided into early or primary postpartum hemorrhage versus late or secondary. The vast majority of early postpartum hemorrhage is due to uterine atony and lacerations from delivery. In addition, retained placenta, particularly placenta accreta. The late hemorrhages tend to have more have retained products as their etiology, inherited coagulation defects such as von Willebrand's disease, and infection. Medical management of postpartum hemorrhage is driven predominantly by the cause of postpartum hemorrhage. Women who develop atony in the immediate uterine atony in the immediate postpartum period are predominantly managed with uterotonic agents, including oxytocin, methyl-ergonovine, 15-methyl prostaglandin 2 alpha, and misoprostol. These are all medications that may have vasoactive side effects. Particularly, methyl-ergonovine is associated with significant hypertension. Oxytocin, particularly if given IV, may lead to hypotension. 15-methyl prostaglandin F2 alpha is to be avoided in asthmatic patients. Factor 7A, concentrated factor 7A, is largely reserved for women with hemophilia. Riostat, which is concentrated human fibrinogen, has become more commonly used for massive obstetric hemorrhage. Its advantage is that it can be stored dehydrated at room temperature and quickly given. We dose it based on the fibrinogen level. Importantly, women who are pregnant have much higher levels of fibrinogen, and it's important to remember that any level of fibrinogen under 200 in a pregnant woman should be cause for significant concern. Women may experience coagulopathic bleeding from several causes, including lack of functional platelets or other factors, as well as DIC. DIC is commonly seen in abruption, sepsis, and amniotic fluid embolism, which is a condition unique to pregnancy. For women who have a lack of functional factors or platelets, replacing clotting components is the mainstay of therapy, as well as treating the underlying condition. Hematology and anesthesiology should be consulted in the management of massive blood product transfusion. In general, the rate at which women lose blood during a postpartum hemorrhage does not allow the timely return of labs, and Treatment should be based on clinical suspicion. In addition, maternal hemodynamics may lag behind their actual blood loss. FFP should be replaced 1-to-1 with red blood cells, and platelets based on the degree. Platelets should be replaced based on the degree of hemorrhage and observed bleeding. In general, source control, including controlling major bleeding sites surgically, removing the placenta, which may be a source of ongoing DIC. If there's severe DIC, it is reasonable to pack and admit to the ICU for delayed closure. Blood product transfusion is largely the same as for the non-pregnant population, with the exception of fibrinogen concentrates that may need to be used in massive postpartum hemorrhage. They should be used when there's not time to wait for emergency release blood. And remember that in normal lab values in pregnant women, fibrinogen is increased. Any value less than 200 should prompt immediate replacement of fibrinogen. We're going to move on now to mechanical ventilation. The need for mechanical support in pregnancy is rare. In a retrospective review of 51 women who had required mechanical ventilation during pregnancy, 43% of them had preeclampsia, 14% had preterm labor, and 12% had pneumonia. The maternal mortality and perinatal mortality rate can be quite high. However, the studies are very small. There is an ongoing question of whether or not delivery improves the respiratory status of pregnant women. There's not good data to suggest that it does. In general, the approach to the pregnant woman with ARDS requiring mechanical ventilation is similar to the non-pregnant woman. First, initial stabilization of the patient and confirm the diagnosis of the underlying etiology. Unlike with non-pregnant women, there will need to be an assessment of fetal well-being and a delivery plan based on gestational age. In managing ARDS in the pregnant woman, it's important to remember that the PaO2 may require higher levels of PaO2 for adequate fetal oxygenation. In addition, there is a need for a PCO2 gradient of at least 10 millimeters of mercury in order to clear fetal CO2. The goal is to mimic normal maternal acid-base status. Overall, it's not thought that maternal survival in ARDS is improved by delivery. However, delivery may simplify management. After 32 weeks, or if the maternal or fetal condition is deteriorating, neonatal survival is good in a tertiary care center with a level 4 NICU. In addition, neonatal outcomes will be improved with a 48-hour course of antenatal steroids. Some of the differences in pregnancy with ARDS, the increased work of breathing with ARDS will shunt blood away from the uterus. The overuse of PEEP will decrease cardiac output by decreasing preload. Remember, the pregnancy norms for ventilation are different. They have decreased functional residual capacity, they have lower chest wall compliance, and pregnant women exist in a state of compensated respiratory alkalosis. It's not entirely known how well acidemia is tolerated. Although, as mentioned previously, it's thought that we need a minimum CO2 gradient of approximately 10 millimeters of mercury. Generally speaking, although lung protection approach has not been studied specifically in pregnancy, it is the standard of care. Minimize barotrauma, set the tidal volumes at 5 to 8 millimeters per kilogram, allow permissive hypercapnia, allow pH to decrease, bicarb only if acidosis compromises the patient. Minor to moderate degrees of maternal hypoxemia will be well tolerated in pregnancy. And remember that the fetal PO2 depends not directly on the maternal PaO2, but on maternal oxygen content and maternal oxygen delivery. In summary, the minute ventilation should be adjusted to maintain a PaCO2 somewhere between 30 and 32 millimeters. This will attempt to replicate normal physiology in pregnancy. PaCO2 less than 30 millimeters should be avoided, as significant respiratory alkalosis may decrease uterine blood flow. And maternal hypercapnia greater than 40 millimeters of mercury may cause fetal respiratory acidosis. Lung protective strategy is the standard of care. However, mild to moderate degrees of maternal hypoxemia are fine. Fetal PO2 depends less on maternal PaO2 than on maternal oxygen content. Maternal hypercapnia may impair fetal CO2 exchange and lower fetal pH. And fetal heart rate monitoring may be useful, particularly in the third trimester, in determining maternal tidal volume and FiO2. If there is significant maternal hypoxemia enough to affect the fetal status, you'll begin to see fetal heart rate decelerations and loss of fetal heart rate variability on the fetal heart rate monitor. Finally, we're going to move to sepsis, which is the other major contributor to ICU morbidity and mortality in pregnant population. In general, the sepsis mortality is decreasing over time, though the total cases are increasing. However, in the OB population, sepsis rates are both increasing as well as rates of severe sepsis and shock. This is a study from the National Inpatient Sample, which looked at 45 million hospitalizations. They had 4,158 cases of severe sepsis during hospitalization for delivery. Importantly, this inpatient sample excludes the antenatal ICU admissions and postpartum incidence of maternal sepsis. So you can expect this number that we see here, which just refers to delivery, to be approximately doubled. And what you can see is that sepsis-related deaths have doubled from 1998 to 2008, and sepsis and severe sepsis have also increased. The treatment for sepsis is similar in the non-pregnant and pregnant populations. Antenatal infections predominantly come from either septic abortions, intraamniotic infections such as chorioamnionitis, complicated pyelonephritis, or pneumonia, including streptococcus pneumonia and influenza. All pregnant women should be offered the influenza vaccination, as the flu can be life-threatening in pregnancy. Postpartum, the infectious sources tend to be from endometritis. Particularly virulent infections with group A streptococcus have been documented, pelvic abscess, and septic pelvic thrombophlebitis. Sepsis management in the pregnant and non-pregnant women are similar. It's important to identify the source and the organism and tailor antibiotic use. Generally speaking, we avoid the use of floxins, doxycycline, and tetracycline, although newer data on some of the floxins suggest that they may be safe. Of note, pregnant women may be less responsive to volume due to hemodynamic changes, and so volume resuscitation should be instituted. However, there may also be the need for vasopressors. In general, all vasopressors and inotropes can vasoconstrict uterine blood flow. The preferred ones are norepinephrine and phenylephrine, as they may be associated with less fetal acidosis and maternal bradycardia. Lastly, I wish to review some special scenarios that occur in the critically ill pregnant women that may be different from non-pregnant patients. A typical assessment of a pregnant woman involves the primary system survey, which you're all familiar with, airway, breathing, circulation, disability, and exposure. However, there is a secondary survey which should incorporate a fetal exam, a check for fetal heart rate, fetal heart tones, a cervical exam to see if dilation and delivery is imminent, a fetal ultrasound, And labs and imaging, including a KB test for abruption, may be appropriate. ACLS in pregnancy, typically you may follow the protocol as if the patient is not pregnant. However, after 20 weeks, manual displacement of the uterus is critical to achieving effective circulation. This is a change in the recent ACLS guidelines in pregnancy. Previous to this, a left tilt was recommended. However, it has been found that it is much less effective circulation with left tilt than with manual displacement of the uterus. Importantly, medications may not circulate adequately if they're infused through the lower extremity. The uterus compresses the iliac veins. Defibrillation should be performed with the same voltage as in non-pregnant patients. In general, with perimortem cesarean delivery, we follow the 4-5 rule. Initiate within 4 minutes of a malignant arrhythmia or maternal cardiac arrest. And again, manual uterine displacement is critical to effective ACLS. The outcomes are optimal in neonates who are delivered within 5 minutes of a maternal cardiac arrest. If the pregnancy is beyond 25 weeks, in a tertiary care center, there is a 45% fetal and greater than 72% chance of maternal survival. In summary, despite advances in critical care, maternal mortality and near-miss morbidity continues to increase. Pregnancy is associated with significant physiologic and hemodynamic changes that may affect ICU management. Hemorrhage, hypertensive disease, cardiac disease, and respiratory failure are among the most common source of ICU admissions. Mortality prediction scores generally performed well, but may overestimate maternal mortality. Uterine displacement is one of the most useful methods to maintain and sometimes augment cardiac output in pregnancy. Under normal conditions, pregnant patients can remain hemodynamically stable despite large volume losses. There is a compromise of oxygen reserve in pregnant women because of decreased functional residual capacity and increased O2 consumption. Early transfer to tertiary setting with appropriate ICU care and multidisciplinary team approach are critical to improving care and avoiding near-miss morbidity and maternal mortality. ACLS protocols do not deviate much from the standard. In trauma and code, keep the 4-5 rule in mind for perimortem deliveries. Pregnant women exist in a state of physiologic respiratory alkalosis. Now we'll review our board questions. Question number 1, progesterone is responsible for which physiologic alteration of pregnancy? A, increased volume expansion, B, decreased functional residual capacity, C, decreased chest wall compliance, D, increased respiratory drive to breathe, E, decreased tidal volume. The answer is D, increased respiratory drive to breathe. Progesterone acts to stimulate the respiratory center in the medulla and increases respiratory drive. Question 2, a 22-year-old gravida 1 para 0 being induced at 38 weeks. Her pregnancy has been complicated by class 3 lupus nephritis, elevated blood pressures, and a new headache. Her baseline creatinine is 1.4 and is elevated to 2.2 today. She is on a magnesium drip at 2 grams per hour for seizure prophylaxis. On physical exam, her deep tendon reflexes are absent and she is not breathing. The magnesium drip is turned off and you are called to see her. What can be given to treat this condition? A, calcium carbonate, 1 gram PO, immediately release. B, calcium carbonate, 1 gram IV. C, calcium gluconate, 1 gram IV. D, calcium gluconate, 1 gram PO, immediate release. E, nothing needs to be given. These are normal side effects. The answer is C, calcium gluconate, 1 gram IV. The patient is suffering from magnesium toxicity, which can occur very quickly in pregnant women with impaired renal function. Question 3, a 42-year-old gravida 3 para 0 with an IVF pregnancy at 31 weeks has ARDS from presumed pyelonephritis. Her temperature is 101.2. She is on lung protective ventilation. Her PCO2 is 58 millimeters of mercury. Her PO2 is 148 millimeters of mercury on an FiO2 of 0.4. When she's placed on the fetal monitor, the fetal heart rate tracing shows repetitive late decelerations and no contractions. What is the most likely reason to explain this change in fetal status? A, maternal hypercapnia, B, maternal hyperventilation, C, maternal fever, D, fetal adrenal insufficiency, E, umbilical cord compression. The answer is A, maternal hypercapnia. Lung protective ventilation can be safely performed in pregnancy if one is mindful of the limitations on permissive hypercapnia in this population. Hypercapnia can result in reduced placental perfusion. Question 4, a 19-year-old won gravida 1 is now immediately postpartum. Her medical history is significant for moderate persistent asthma. Her nurse called the OB in for excessive bleeding, which was managed successfully with an IV medication. You are now being called to evaluate the patient for new onset wheezing and desaturation to 88%. What do you think precipitated this event? A, use of methyl ergonovine. B, pulmonary edema from IV fluids. C, oxytocin infusion. D, coincidental asthma exacerbation. E, use of carboprost-tromethamine. The answer is E, use of carboprost-tromethamine. Bronchospasm is a known side effect of medications in the prostaglandin F2 alpha family. If given to a patient with an asthma history for the treatment of postpartum hemorrhage, it can participate in asthma exacerbation. Question number 5, you are called to a code on the labor and delivery floor. The primary OB suspects an amniotic fluid embolism. Which of the following statements is false regarding the management of this coding pregnant patient? A, medications through femoral lines may not circulate. B, if she needs defibrillation, it should be at a lower voltage for fetal safety. C, hand placement for chest compression should be higher than for non-pregnant patients. D, coagulopathy is a key feature of this disorder. E, a perimortem cesarean delivery should begin by 4 minutes into the code for better fetal outcome. And the answer is B, if she needs defibrillation, it should be at a lower voltage for fetal safety. ACLS guidelines for cardiac arrest in pregnancy are well established and do not deviate much from non-pregnant patients. Defibrillation is not harmful to the fetus and should be performed with the same voltage as non-pregnant patients.